and welcome to CalHIPSO's educational webinar series. Today's webinar, we are joined by Vigilance Health, and the title of this webinar is Population Health Strategies to Improve Practice Quality and Revenue. My name is Chloe Scholl, and I will be the organizer for this webinar. All attendees will be muted for this session. However, if you have any questions throughout our time, you can submit them in the chat box. And if time allows, we will try to answer a few questions at the end of the presentation. Today's webinar is being recorded, and the recording will be available at www.calhipso.org in the next few days. I would now like to introduce the Executive Director of CalHIPSO, David Ford.
Thank you, Chloe, and thank you to everyone for being in attendance on today's webinar, the latest in the CalHIPSO webinar series. If you like today's webinar and you're interested, we are keeping this series going on the second Thursday of every month. And a little later in the broadcast, I will tell you about December's webinar. Now, for those of you who are on the phone today who may not be aware, I will just go very quickly a little history about CalHIPSO, who we are, and what we do in the marketplace. CalHIPSO was founded in 2010 by a really unprecedented joint venture of three of California's largest provider associations, the California Primary Care Association, the California Medical Association, and the California Association of Public Hospitals and Health Systems. CalHIPSO was an officially designated regional extension center for health IT, the largest of the 62 federally designated recs by provider census, and in that role help providers in California navigate the complicated world of electronic health record adoption and achieving meaningful use. As I said, CalHIPSO was originally formed to be the rec and was solely focused on helping providers reach meaningful use, but as time has gone on and the needs have become more diverse, CalHIPSO has branched out into many areas. Some of the current projects that we're working on are up on the screen, including, yes, a little bit more of Medicaid meaningful use, but also the quality payment program and MIPS and Medicare, diabetes data reporting, some encounter data work, and a big project that we're about to start on helping providers onboard to health information exchanges. Across all of the programs to date, over almost 10 years, CalHIPSO has provided assistance to 13,000 or so unique clinicians spanning more than 1,400 provider organizations statewide and helping them earn more than $250 million in federal incentive payments across several programs. As Chloe mentioned earlier, today on this call, we are joined by our longtime partners at Vigilance Health. And our faculty for today are James Coburn, the founder and executive director of Vigilance Health, and Mark Davis, the population health development manager. And you see a little bit of their bios up there on the screen. And I think without any further ado, we will turn the program over to Jim and Mark. Take it away.
Great. Thanks, David.
Thank you.
Thank you, Chloe. So, and welcome, everyone. My name is Jim Coburn. I'm the Executive Director of Vigilance Health. And as David had said, I'm here with Mark Davis, Population Health Development Manager.
Good afternoon.
And we've got a full agenda today of information that we want to share with you all. And you know, we oftentimes just remind folks that maybe it's better to just, rather than try to write everything, we'll get it. Chloe and CalHIPSO will get information out to everybody. Maybe just stay with us and because the information is kind of dense and we're going to move through it pretty quickly. And we are also going to have time for questions. So maybe think about your questions and type them into the question section. And Chloe will kind of we're going to try our darndest to make sure we got plenty of time for Q&A. So again, welcome everybody. We first of all, I'm going to move through. David had just announced our kind of partnership with, we really have been longtime partners with CalHIPSO. The organization is called Vigilance Health. Our mission here at Vigilance is to simplify our providers' lives and enable our providers and clinics to measure and demonstrate, ultimately improve patient outcome scores. But back in 2014, late 2014, we modified or updated that mission, I should say, and brought the patient into the center. And we have a mission to empower our providers' patients to take a more proactive role in their own health outcomes, and this is done through population health management, and which population health management involves a very high degree of patient engagement, patient education, and accountability. And just a little quick background: we're part of the federally designated extension center program, as David had mentioned. We've been working with CalHIPSO not since day one, but it was pretty close to day one. I think it was way back in the inception of the program at 2009, when I think CalHIPSO probably was at employee number 1 or employee number 2 or whatever. So we've had a nice long good working relationship with CalHIPSO under the federally designated extension center program, and we assisted over 5,000 providers in that program. We work with a large number of FQHCs, but then also it's probably 50% independent clinics and hospital-based clinics. And we have become a quality improvement partner to our healthcare organizations. And on the screen now is just a sampling of some of our partners and organizations that we work with. And what otherwise used to be the majority of California work has now branched into many other states now, and we're excited about the prospects of healthcare and healthcare transformation and even payment reform. As much as you can be excited about something that can tend to be a little bit painful or sound painful, we're excited about it because we are educating folks on how to kind of navigate their way through this in a painless way. And this is just a quick snapshot of a press release announcing a new strategic partnership with CalHIPSO. We've always had a partnership, but it's a new strategitic partnership around educating organizations on population health management strategies. And so just as we wrap up kind of the background of Vigilance Health, we develop population health management strategies for healthcare organizations, provider organizations, that, number one, increase revenue, improve outcomes, provide a pathway for getting patient engagement and patient compliance, which generally equals better patient satisfaction, and also provider satisfaction. Provider satisfaction is that kind of that all-encompassing word that folks are looking to achieve to combat physician burnout, and we all know that there's a lot of that out there. The strategies that we advocate and that we educate folks on are based upon the individual needs of those healthcare organizations or the patient panel needs. And we do consider ourselves a quality improvement partner. We're not a vendor. We are first and foremost an educator. We're subject matter experts on population health, and we become a partner to healthcare organizations in their endeavor to move through this process. And we operate from the premise that an engaged patient generally equals a more compliant patient, and a more compliant patient generally has better outcomes. And so, however, we also are operating from the standpoint that providers are doing the best they can given what they've got, and given their resource constraints and their time constraints. All providers generally want to do the best that they can for their patients. However, as a healthcare organization, if we keep doing what we've been doing, now we're doing it a little bit differently with electronic health records versus paper records, but if we just keep doing what we've always been doing, we're going to keep getting what we've always gotten. And so therefore, it is our endeavor to help clinics and medical practices and healthcare organizations and providers answer a very fundamental but powerful question. And that is, if your reimbursements are currently or soon to be, will be tied to patient outcome scores, what are we going to do to get better patient outcome scores? And although that may appear to be a very fundamental and simple question, it is in the answering of that question that our purpose and our cause and our passion lies. And And we've been developing population health management strategies and educating organizations on these strategies for quite some time. So let's dive into it. So let's look at the landscape. Clearly, this is not the landscape that most people are looking at when they look out their window. However, when we look out the window of our transformation efforts, it might look like this. Where do we start? What do we do? Oh my God, payments are going to start being tied to patient outcome scores. Where do we even start for that matter? I don't know. I like looking at this. I'm not a mountaineering expert, but therefore that makes me qualified to say this. I don't know where I would start at this mountain. If I start on the left or I start on the right. So let's look at the problem first. The problem that exists, and you've all seen these statistics many times in many different ways. The bottom line is healthcare expenditures are set to, if we don't do anything, they're set to almost double in the next 9 or 10 years, and which is going to do wonders to our economy if we don't do something about it. And when you look a little bit deeper, what you'll find is, for example, 93% of Medicare spending is on the 2/3 of beneficiaries with 2 or more chronic conditions. The overwhelming majority of the money spent today on healthcare are for patients with 2 or more chronic conditions. We do, I know this is maybe arguable, but we do acute care well in this country. It's all of the other challenges that we're not so good at, and the other challenges are patients with chronic conditions that they've had for many years and that they're going to have until they die. How do we get those patients better managed, better controlled, better engaged for better compliance? To make matters even more challenging, we've got a situation where, in terms of running your practice and your business, your payments are slowly but surely, well, actually, slowly is arguable. The government's goal, as stated several years ago, was that they wanted 90% of payments for healthcare services tied to outcome scores by the end of 2018. Now, we're not quite there yet, but I can tell you with great confidence, the train has left the station. I saw a report, I don't know, maybe about a week ago, that stated that overall, not only Medicare but private payments, that greater than 50% of the dollars that are being spent today in terms of reimbursing providers and hospitals for healthcare services are now tied to some form of performance. And so clearly we're well on our way, and so the question is, how does a healthcare organization position itself to achieve better outcomes? Because if your payments are tied to outcomes, that's got to be a focus. And so we advocate developing population health management strategies. And so we have to first kind of get a level set on what is really population health management. You could talk to a lot of folks and you get a lot of different definitions, but the bottom line is certainly patients will always be individual, and their care will always be delivered on an individual patient. And a patient's care and care plans are individualized to the particulars of that individual patient. But there are populations that we can identify and define, so that we then can employ interventions to get better outcomes. And a good population health management program has got to have these core areas. First, we got to define our populations, our various populations, defining them and segmenting them either by payer or by age group or by disease state, and identify the gaps in care quickly, stratify the risks. All the while, we got to get the patients better engaged, and we're going to talk about that in a minute, so that we can manage the care and measure the outcomes while we're doing it, and have a robust mechanism for doing that, so that we can move the needle on outcomes. Certainly, we're looking to reduce readmissions, hospital readmissions, reduce non-critical ER visits. But the challenge with a healthcare organization is that we have a little bit of a dilemma, in the sense that if you don't have the internal capacity to do this, or the technology or the human capital to support this transition, it's going to be challenging for you to move through this transition. Right now, it still kind of feels like we're working in a fee-for-service world. But to be clear, 50% of your payments coming from your various payers are being currently influenced by your outcome scores. And so really, we like to categorize this as a movement. It's not just a government edict. It really is more of a movement. And the movement is a move away from volume and over to value. It's stated in a lot of different ways, but moving away from fee-for-service and over to pay-for-performance. And all roads really are, and all eyes should be focusing on population health management. And it's not a matter of really, if you're going to join it, but when you're going to join it. And I submit that we've all actually joined it, whether we like it or not, because the payments are already being influenced. And so really we advocate developing a strategy that's right for your organization. And it's our endeavor to educate folks that strategies do exist. Very powerful strategies exist, and strategies that can have a significant impact, not only financially, but also clinically, of course, and can help to propel the organization, or at least position the organization for these risk-bearing contracts that are coming down the pike. And some of you all are even already in some of these risk-bearing contracts. Some of you are a part of ACOs and a part of managed care contracts that are risk-bearing in some fashion. And so let's look first at the strategy. Number one, we've got to look at the core domains of a robust population health management program. And the first thing is, of course, we've got to be looking at care management. The whole break-fix model of patient care is not going to work well in a value-based contracting environment. So care management is key. We've got to identify high risk and the rising risk patients and get them better engaged, better coordinated, better managed for better compliance. We also have to be looking at disease management. Disease management has been around for a long time. It's a key component of population health. We look at the disease states. We look at our patient panels by certain diseases, and we've got to employ best practices to slow the chronic disease progression. And then we always got to be having our eye on reducing costs. For example, reducing those non-critical ER visits. I mean, if they're non-critical, we should be coming close to eliminating them. If we can implement strategies or avenues or resources for the patient so that they don't have to use the ER as their primary care doctor in off hours, then we have saved the system a tremendous amount of money. And that's just one example of many. We got to identify and close gaps in care. By identifying and closing gaps in care, you as a healthcare organization can have an immediate impact on your clinical quality measure scores, and therefore an immediate impact on your reimbursements. And of course, patient loyalty. Patient loyalty is a big issue. Not only is it big for your organization, you don't want to be losing your customers, but you don't want to be spending a tremendous amount of time in getting patients better engaged, only to have them leave out the back door and move to another provider organization. And it's our position that if you're providing good care management and good population health management, your patient satisfaction scores skyrocket. And so therefore, so does your patient loyalty. All right, so in terms of the strategy, we have been advocating and educating organizations on looking at population health with a new set of glasses, but from the standpoint of what are the various components that we can do right now that can have an impact not only financially but also clinically on our patients right now. And so we we advocate that one look at a population health management strategy that encompasses 4 key services. Now, we don't advocate or educate folks that this would be your entire population health management strategy, but to start here can really propel your organization very quickly and get early wins. And I don't only mean early clinical wins, I also mean early financial wins. Each and every one of these services listed up here has a financial component and a key clinical component or components. And We're going to go through these just in a little bit more detail, but what these acronyms are, and we apologize for the sizing there on the text. I think it got screwed up in the transfer. However, first block, chronic care management or general care management. This is a very effective program to get the patients in, get them engaged, get them better educated, set goals so that the patient can be much more engaged in between their normal primary care visits. Annual wellness visit, or AKA patient assessments, to identify and be able to do an extensive assessment on your patients regularly, at least once a year, enables you to identify and close gaps in care, and it also has an impact on your risk adjustment factor. For those of you that don't know what a risk adjustment factor is, you're being graded right now behind the scenes, and you are being assigned a risk adjustment factor. That number is important to you because you can use this in your negotiation for your payer contracts in the future. You want an updated, accurate risk adjustment factor. The only way to do that is to have updated data and diagnoses about your patients. And the only way to do that is to do a regular in-depth assessment about your patients. Now there's reimbursements attached to it, so there's additional incentives to do this. Remote patient monitoring is the third in the block there. Remote patient monitoring is a new and exciting area where we now have resources, you now have resources to offset the cost of collecting data about your patients. So for example, if it's a diabetic patient, we want blood sugar numbers. It does not have to be collected electronically, although that would be best. This could be patient-reported data. It could be electronic data. Nonetheless, there are reimbursements attached to the activities surrounded in gathering that data about those patients so that we can aggregate that data and provide that data back to the provider in between their normal follow-up visits. The last one, collaborative of care management. We now have a phenomenal method of capturing those patients that are falling through the cracks, that are suffering from mild to moderate behavioral health conditions. For example, patients that are suffering from depression or anxiety. I can't tell you how many patients we see from a primary care setting that are suffering from mild to moderate, depression or anxiety, that are just falling through the cracks. They're not getting addressed. And to have an avenue to address this for patients and a reimbursement is phenomenal, because now that patient has a voice, and they can now be heard, and those conditions can be addressed. They're going to be far more willing to and able to comply with their primary care doctors or providers' directives around diet modification or lifestyle or exercise or taking their meds the way they're supposed to, if they're no longer suffering from depression or anxiety. And so now there's additional resources, and for those 40% of the patients, primary care patients that are suffering from that. And so another way to look at this, we have a graphic on the screen. Another way to look at this now, and we invite you to just imagine right now what your typical workflow is for your patients. Imagine that the patients are seen maybe every 90 or 120 days. Oftentimes our clinics or practices will tell us, well, yeah, that's if they're lucky. That's if they show up for their follow-up, right? But let's just imagine that in this case, we have a patient that comes in and they're not seen on follow-up for another 3 months. So what is going on with that patient in between those normal follow-up visits? So they're in for a clinic visit, and then they go home, and what are the providers doing? Well, the provider is moving on to the rest of the patients. The provider and the staff, they don't have time to do anything with those patients. They just got to hope that that patient is compliant with the directives that the provider gave to them. And it's really kind of like a hope and a pray, really. And most providers tell us, gosh, if I could just get my patients to do what I tell them to do. Yeah, well, good luck, because this is human nature. Most of what happens inside of an exam room is either forgotten or not fully understood within a couple of days of the office visit. And so what we have is a mechanism that is not geared for patient compliance. And so now we have resources, not only financial resources, but mechanisms to address that gap. And therein lies the most significant gap in healthcare today. What is happening to that patient in between visit number 1 and 3 months later, the next visit? What's shown on the screen now is a graphical depiction of all the additional touch points that we can, or that you all can, given a robust population health management strategy, can employ to keep these patients engaged in between their normal in-person office visits. And we didn't even have enough space to show every single one of the touch points that are available. So there's chronic care management or general care management that can happen every other week with a patient on a non-face-to-face basis. There's remote patient monitoring. There's AWV or patient assessments. There's collaborative care touch points with those patients. Literally, these patients can, depending upon what the conditions they're suffering from, can have in upwards of 20 or so touch points in between their normal follow-ups. Now that is a powerful mechanism for better patient engagement, better patient education, better patient compliance. And when we have better compliance, we always have better outcomes. And so the challenge, though, is, well, we don't have the time or the energy or the staff or the wherewithal or the resources to provide all these touch points. Well, that's what these new population health management service lines can do. And so when done appropriately and efficiently, we now can have a patient base that is far more engaged, and icing on the cake for organizations, the revenue is significant, and when done appropriately, can provide a significant net revenue after expenses, so that the clinic or the medical office can now have additional revenue to offset either other cost categories for other salaries or other population health management programs. So I'm going to turn it over to Mark, and he's going to kind of walk real quickly through each and every one of these items, and then we'll move into the financial component.
Great, thanks, Jim. So for chronic care management, it really is the first step in a good strategy behind population health management, really the foundation. There's never been a service or a reimbursable service to shadow the patients in between their follow-up visits with their provider until now. And this service really helps the patients stay on top of their provider's directives. So when they show back up in the office, the practice, the clinic, they have been managing their diabetes, they've been managing their hypertension, and so this is a great alternative additional touch point in between those visits with the physician. And this is non-face-to-face activities for the patient. So a lot of this work is done by clinical staff by phone with the patient. So the next service is the Medicare annual wellness visit. Okay, so not to be confused with the annual physical, but this is the first step in closing gaps in care, going one for one on those clinical quality measures, no matter what your measure set is. This is capturing data through a health risk assessment, identifying those preventive services under CMS's standard clinical guidelines, and beginning to close those gaps. And this is so synergistic with chronic care management. So our next service is the remote patient monitoring. Now, this is a new service for 2018, just came available. This is not telehealth. So what it is you're capturing the data points from the patient-reported data points, and sharing those with the provider, the care team, all of the providers within the continuum. And this is shown to avoid major events. And so it's a great new service for clinics and practices. The last one here is the Collaborative of Care Management. This is also a new service for 2018. As Jim had mentioned, it's finally a pathway for behavioral health patients. And this is really, it is the care management for the patients that have a behavioral mental health condition. And rather than receiving the chronic care management or general care management, this would be the service to provide to those patients. So there are so many benefits to implementing and providing these services to your patient populations. One, there is a significant increase in revenue so that organizations can get paid now while they make this transformation to value-based care. And we have seen in the pilot programs that they were beneficiary to the clinics and the practices, because we reduced hospital admissions and readmissions, and we kept the patients out of the ER on the weekends and got them in to see their PCPs on Friday or Monday. So we were avoiding those non-critical ER visits, and of course a major reduction in cost for the patients, a 6% reduction in monthly cost per patient that are participating in these programs. And this is felt all around in the patient's care. And then also monitoring the patient's condition and avoiding those major events, and collecting that data and getting that to the provider or the care managers. So just an example of how we can move the needle on quality improvement. Here's a clinical quality measure for controlling high blood pressure. And so through care management and care coordination, we are managing the patient's medication compliance, MedRecs constantly in between follow-up visits with the providers, making sure that the patients aren't cutting up their meds, or actually they were able to pick up their medication. A lot of patients have a financial hardship. They have transportation issues. We can identify that early, and we can overcome that obstacle and get them back on track. So when they get back in to see their provider, they're having good outcomes. And so through motivating them for a healthy diet, for exercise, to get up and move around a little bit. I mean, it's life-changing. And to help them, depending on their condition, of course, under this measure, we would help them manage their blood pressure and get them active in measuring their BP and getting that reported back to the clinic or to the care manager. Okay.
All right. So oftentimes when we talk about those types of activities, it generates a picture and a response of, well, that all sounds really, really nice, right? That sounds really nice that, okay, we can work with these patients, and we can shadow these patients, and we can coach these patients, and we can find out, if they're taking their, if they're not taking their medication the way that they're supposed to, or if they're having transportation problems. But we're just having difficulty getting through the day, seeing the patients that we've got, let alone doing all this other stuff that all sounds really nice and dandy. So let's talk about that. Let's turn the floodlight on the challenges with a population health management program, and so that you all can kind of go into this with your eyes wide open on what it's going to take to do this kind of work. And so first and foremost, we want to look at the considerations and the challenges in terms of operationalizing these. And the three primary areas for considerations and challenges, as with most other initiatives, it falls under people, processes, and technology. And you want to look at what are those resources and technologies and policies and procedures around actually doing this work. So let's move into the staff consideration, the people section first. So first and foremost, providing population health management services, you have to look at this as work that is essentially, it's different than encounter-based care, because quite frankly, most all of this work is done when the patient is not in front of you. They're at home. And so most all of a medical practice or a clinic's work is when the patient is right in front of us, except for maybe a lot of those those follow-up telephone calls to get them scheduled for here or to get them scheduled for that. But for the most part, everything resides right there, face-to-face or in person. They're in the waiting room or they're in the exam room. And so we advocate that you look at this from a different type of a workflow. And the first thing that we want to do is get really real with ourselves and say, well, we have staff that are busy working full-time every single day, concentrating on the patient flow within our clinic. If you take from that, it's going to break something within your current operation. And so we many times advocate, don't do that, create a different team. And that different team is going to look like care managers, team leads, some oversight or management, and then a focus on quality control or quality improvement, so that all of these people that are assigned to these tasks can be focused in on the task at hand and continuously get better. And what are the expenses associated with it? Well, it's payroll. You got to find the right people, so it's recruiting, it's ongoing training. You're going to have some space. It doesn't necessarily have to be clinic space, but you're going to have some space to house these folks. And then you're going to have some infrastructure, either population health management software or some type of platform. Some folks have tried this utilizing their own electronic health record system. The challenge with that is that the EHRs are specifically designed for encounter-based care visits. And so the workflow and the activities and the tasks that need to be tracked with patients regarding population health management services are really actually different than encounter-based care. And so you'll find it to be quite cumbersome if you use your own EHR. So we many times advocate utilizing a different software platform. And then, of course, everybody's going to have computers and phones. And so in terms of the staffing considerations, it does add up pretty quickly because it is time-consuming work. And so let's take a look at a basic estimate, right? We're going to look at a practice with 1,000 patients and a practice with 500 patients. And for this example, we're going to keep it simple and just focus in on care management. You'll add staff based upon the additional services of annual wellness visit, remote patient monitoring, as well as COCM, collaborative care, and behavioral health integration. But let's just look at it just from the standpoint of care management. For 1,000 patients, you'll need to do a basic calculation that each one of those patients is going to be attended to for at least 40 minutes per month. You can't go below 20 minutes. That's the billable requirement. But in our experience, it's difficult to get it below 40 minutes, which means that you're going to take it all the way out to 670 hours or 6 FTEs, 6 full-time equivalents of care managers. That does not include management time. You'll have to assign some time for management. In your operation, will you need one full-time manager for 6 care managers? Maybe, maybe not. And every operation is a little bit different. For 5,000 patients, on the other hand, let's go straight across the line, and you're going to need 28 FTEs. So clearly, I think we've just found out why most people haven't jumped headlong into providing these services. Most folks are looking, you got to be kidding me, to hiring 28 more people to do this, and so yeah, it's daunting. However, there are significant benefits to moving into this direction, and it will require you, if you do these services under your own roof, it will require you to morph your organization. And now, clearly, the next obvious question most folks come up with is, where the heck are we going to find the money to pay all these people, even if we did want to hire all these people? Well, the program and the revenue will not, if done efficiently and done correctly, it will not only cover all of your costs, but you will have a significant net revenue after all costs. And so, to be clear, there's plenty of resources available to you to do this and to launch this. And we'll show you that in just a minute. Before we move into the financial section, let's look at the process though, and we'll work with David Ford at CalHIPSO to create maybe a series of educational sessions on a deep dive on each and every one of these services to really show you maybe a deeper dive on the nuts and bolts process considerations. However, at least at a top level, you're going to need to have an understanding that there are operational considerations, because these services represent new workflows and, to a certain extent, new clinical pathways. These are non-face-to-face activities, and so therefore the care managers and folks that are doing these population health management services really need to be focused in on better outcomes, and as opposed to just calling the patient and seeing how they're doing. We really need to use this time and this resource to set goals with a patient and to identify obstacles and to get those obstacles overcome and to pull the patient into the process. And there are new pathways and workflows that need to be developed. As I said, we're subject matter experts, and we can educate you on these pathways so that you don't have to figure it all out on your own. And we can provide those educational sessions and do a series with CalHIPSO for you. But suffice it to say, there's new clinical pathways and workflows, and generally speaking, a different set of clinical quality sets, different than what you may be focused on today. And we, of course, want to mirror on what your payers are demanding from you. And so let's look at some technology considerations. As we said, the EHRs are not generally well suited to be tracking population health activities and tasks. And so you really want to be looking at a different software platform, and you'll have that process of selection, and you're going to have to get into pricing and negotiation, and then you're going to have to look at implementation and training. You'll have to kind of budget for that so that your team can be operating efficiently. And the other reason is because you ultimately want team members that are spending 95% of their time directly working with a patient. You don't want them spending 50% of their time documenting and 50% of their time working with patients, or else the financial model will fall apart. So so you need a technology that's going to keep your team as efficient as humanly possible, or as technologically possible, I should say. And so this is why we really, really advocate that you use a system that's specifically designed for these activities. And so let's look at the financial considerations. So the financial considerations are we're going to base this on hypotheticals. And we also want to offer to our folks that came on today with a population health management strategy report, where we can develop some numbers that more closely match your organization. And that is an offer that we'll do for you. We'll talk to you about that in just a second. But before we do, I'm going to turn it over to Mark, and he'll just kind of walk you through how these revenue items work and how they're generated.
Yeah, so we're close to the end of our time, so I won't take you through each specific dollar figure, but this is an example of two different size organizations, one with 1,000 patients and one with 5,000 patients. We, typically with organizations that we've worked with over the years, for chronic care management, we've been able to get about 80% participation of their eligible patient populations. And so those numbers are based off of 80% of the population coming into the program and getting them engaged and coordinated. The figure is the patient population multiplied by the national average. And so that's how we arrived at these figures. Also, and we work with organizations that are bringing in this revenue now. This is gross revenue. This is before any cost, no matter what your implementation model was. And so it's significant revenue for rolling out these services. It may not make or break an organization, but definitely this these are added services. So this is added revenue streams over and above what organizations are bringing in right now.
And I'll just add just really quickly, although as Mark had said, these are gross revenue figures, you can basically look to achieve about a 30 to a 35% net profit if it's done efficiently. A 30 to a 35% net profit after all expenses, and it's generally in the same ballpark whether you were to do these under your own roof or if you were to outsource these services. And you know there's some economies of scale that an outsourced organization can get that an individual clinic cannot get. So your net revenue might be a little bit better if you outsource it, but generally for planning purposes, you ought to just right off the bat, if done correctly, 30% to 35% of that is net to the practice or to the clinic, which kind of brings us to the point that what we find most of our clinics and practices as a good starting point for determining if these services are right for the practice. Well, let's face it, the value-based train has left the station, and if you're seeing patients and you've got chronically ill patients, you're going to want to do something, some population health management services to stay viable, really, because your reimbursements for providing healthcare services are tied to outcomes. And so, however, one of the things that a lot of our folks have found to be quite useful is, as a starting point, look at the financial a financial calculation based upon their given patient population. And we had mentioned earlier that we can provide a population health strategy report. It really serves as a starting point, as a discussion point for folks within your organization. Is this something that we ought to think about doing? And we'll need some information from you in order to produce this report for you. This is kind of a screenshot. There's clinical quality improvement estimates that we can provide within this report, as well as revenue estimates that we'll provide. And for those of you that would like that, what you'll want to do is just type into the chat or into the questions, just type in Pop Health or report or something to indicate that you'd like that. And then we'll get with you. There's a couple of key, just really basic pieces of information that we'll need. It won't take you, actually, you'll probably know it off the top of your head. And we'll get with you, we'll get that information, and then it'll take us a few days and we'll produce this report back to you. And then this is something that you can use as kind of a discussion point within your organization if it's something that you want to, if you want to get more information or learn more or get more education about how to do.
So I think that's it for ours.
Yeah. So I think we've got time for questions.
I think we're sending it back to
Chloe,
David and Chloe.
Yeah, that's right. So our next slide, we have Q&A, and I will be reading off some questions, and then you guys can answer. So our first question is, in your domains, you mentioned patient loyalty. How does this increase patient loyalty?
Well, okay, yeah, good question. So patient loyalty. So what we found is that, and this is a astounding statistic that we just found recently, and then it was substantiated by another large organization, by Dignity Health, as a matter of fact, and that is that when the patients received a communication, a live body communication via telephone, from a care coordinator, a navigator, any human being really, soon after their most recent visit, patient satisfaction scores skyrocketed, and it was astounding how high it went up, and it was clear that the patients have an insatiable appetite for feeling like they're really being cared for, and so therefore, any touch point that we can add to the care that they're getting in their normal primary care visits will have a significant impact on patient satisfaction. that has a significant impact on patient loyalty. And so that is how patient loyalty is impacted. Hopefully we answered your question.
Thank you. The next question is, can we bill CCM and RPM in the same month for an individual patient?
You want to take that, Mark?
Yeah, you can. I mean, all of these services are very, I talked about how chronic care management and AWV were synergistic, but they really, all of these services, all four of these services work together in unison for the patient and to benefit the patient. And so, yes, the answer is yes, because CMS realizes that, and so that it can be billed out the same month. You want to be capturing those data points for the patients, and you want to be providing that support for the patient month in and month out. And that can be many touch points throughout the month.
Good question.
Thank you. The next question is, what numbers do you need to know for the strategy report?
Okay. Well, so go ahead and take it, Mark.
Yeah. So these services are available to most of the patient populations. However, we typically start when we're working with an organization to provide information on planning. We typically start with the Medicare patient population or Medi population, and then start from there, and then help them look at their full payer mix.
So as far as the report is concerned,
yes,
we just basically need your Medicare and your Medi population.
Yeah.
Your current Medicare and Medi population.
And that can be original and Advantage.
Great, thank you. Our next question is, do these services help to improve my MIP score?
Yeah, very, very good question. Yes, the answer to that question is yes, and in several ways. So your MIP score, and CalHIPSO did a great education on the merit-based incentive payment system and the various categories. And you'll undoubtedly see more from CalHIPSO on this topic. But there's 4 primary categories that make up your MIPS score, and these population health management services have a direct and indirect impact on your MIPS score from several areas. Not only, number one, identifying and filling gaps in care, immediate impact on your quality numbers, which has an impact on your MIPS score, and then the the clinical practice improvement activities, CPIA, clinical practice improvement activities. We're living in a world of acronyms. That portion of your MIPS score requires a provider to implement clinical practice improvement activities. And there's a list of, I think it's like 90 or 95 things that you can choose from. Chronic care management, we advocate, why not pick one that has the highest impact on patient care and money? And chronic care management is on that list, along with a host of other things. But by merely implementing chronic care management, you'll have an impact on that category of your MIP score. And we could spend another 30 minutes talking about that. So most definitely it has an impact on your MIP score.
The next question is, do my physicians do this type of work?
Go ahead, Mark.
So it depends on the service, but only for physician involvement, a little bit for certain organizations for the AWV because it is a requirement for billing. But typically this is clinical staff, RNs, because this is below the provider license, MD, DO, NP, PA. This work is very labor intensive, time consuming, but should be done by clinical staff. So RN, licensed clinical social workers, LVNs, CMA support in some of the services, and
Mark, and the way Mark answers this question, I think is great and educational. But we go hit it right at the head. Don't ever have your providers engaged in these activities, because the mantra in healthcare today in general is get our most expensive resource to be doing the most important activities. And so therefore, docs should be practicing at the top of their license. And if they're engaged in any activity that's below that, they should stop it. Because we have resource problems, physician shortages. They got to be seeing patients, and diagnosing, prescribing, and treating patients and moving on to the next patient. And so, no, do not let your providers do this work.
Yeah, this is work done by care teams and just a kind of a force multiplier for the physicians and an extension of their arm.
Great, thank you. The next question is, any information on reducing no-shows at the clinic?
Yeah, good question. In chronic care management, we have moved the needle on no-show rates. We find, with the care management team being in contact with the patients on a regular basis, they'll see when the patient is going to be going in for an appointment with their provider. And so they're checking in with them, making sure, well, of course, reminding them about their appointment, but they're also making sure that there's no challenges around getting into that appointment. So we find that a lot of Medicare patients have transportation issues, but there's a lot of community resources out there that can help with that. And so that's what the care managers are doing, and they're getting those patients in to adhere to their appointments.
Great, thank you. It looks like we have time for one more question. So the last question will be, can I provide these services if I'm part of an ACO or an IPA?
Yes, these services, we work with practices and clinics that are part of ACO and IPAs, and this is definitely the focus for those types of organizations in closing gaps in care and getting better patient engagement and adherence to medications and all of the preventive services. And
it's actually part of your charter for being included as a provider within an ACO or IPA. They're kind of expecting you, to do these in a way. And most definitely.
Yeah, good question.
All right, that wraps up our Q&A portion of this webinar. And now I'll hand the mic back over to David Ford, the Executive Director of CalHIPSO.
Thank you, Chloe. And I'll run through a couple things right as we're coming right up to the top of the hour. Our next CalHIPSO webinar is on revenue recognition through coding optimization. We're trying to stick with a schedule of having all of our educational webinars fall on the second Thursday of the month. So in December, that puts us on Unlucky 13. So Thursday, December 13th from noon to 1. See a brief summary, and if you're interested in registering, there's the link. Thanks. Sorry, I'm struggling with the word there. There's a link. This webinar will go through new standards and some practical considerations for implementing quality care benchmarks in a practice management revenue solution. And this one will be a pretty deep dive, and I think we're pretty excited about it, and offer some interesting opportunities for practices to recognize new revenue just through how you manage your data. So we're really looking forward to that one. Hope you'll join us next month. And a couple of just last notes. I hope everyone will circle on your calendar May 13th, 2019. It is a Monday, and here in Sacramento, we will be having the first ever CalHIPSO conference, which we have dubbed Health IT After Meaningful Use. At our conference, we will be discussing, as the name indicates, what does the world of health information technology really look like as meaningful use starts to wind down. You know, on the Medicare side, we've already gone into MIPS, and the Medicaid side, meaningful use will go on for about another 2 more years, and then we'll wind down. And at our conference, we're going to be talking about a whole host of things, or which will come after meaningful use: payment reform, medical dental integration, health information exchange. So we're really excited about it. We hope you will watch for more updates about the conference and join us in Sacramento next spring. And on that note, if you want to receive updates about the conference, our upcoming webinars, and everything else going on at CalHIPSO, including when there are new rules both at the federal and state level that impact your practice, you can send a note to info@calhipso.org if you're not already receiving our update emails. And just let us know. We'll make sure we get you on our email list and that you receive those updates. With that, I would like to give one last thank you to our panelists for today, Jim Coburn and Mark Davis from Vigilance Health, our longtime partners here at CalHIPSO. And a thank you to Chloe Scholl for organizing this webinar and putting everything together, and of course to all of you for attending. With that, we will close down the webinar, and we hope we will see you on the 13th of December. Thank you very much.
Thank you all.